Please have a seat. I would very much ask all the people having conversations, team. Okay. So I wanted to welcome you to this very important session in which we are honoring Dr. Marta Denckla. I would like to say a few words about that. I'm Joe Biederman. I'm the president of APSARD, and it's a real pleasure to introduce Dr. Denckla at a personal level. I had the honor and privilege to be a fellow when I did my training in child psychiatry with Dr. Denckla, and she was an inspiring component of my interest in ADHD and my career. So it's uniquely gratifying to me to introduce her. Dr. Denckla is a research scientist at the Kennedy Krieger Institute. She previously served as the director of the Developmental Cognitive Neurology Clinic. She is also a professor of neurology at the Johns Hopkins University School of Medicine. Dr. Denckla graduated summa cum laude from Bryn Mawr College and went on to graduate cum laude from Harvard Medical School in 1962, where she trained with Dr. Norman Geschwind in behavioral neurology. Dr. Denckla served residencies at Beit Israel Hospital and Veterans Administration Hospital, both in Boston, as well as Georgetown University Medical Center in DC. After positions in neurology at the College of Physicians and Surgeons in New York and Harvard Medical School, she serves as the director of the Learning Disability Clinic at Children's Hospital, where I had the privilege of meeting her. She came to Maryland in 1982 to serve as chief of the section on autism and related disorders at the Developmental Neurology branch of the Neurological Disorder Program at the National Institute of Neurological and Communicative Disorders and Stroke at the NIH. She came to Johns Hopkins and Kennedy Krieger Institute in 1987. Dr. Denckla serves as director of the Developmental Cognitive Neurology Clinic at Kennedy Krieger Institute and held the Batza Family Endowed Chair at that institute. Dr. Denckla is a past president of both the International Neuropsychology Society and also the Behavioral Neurology Society. Dr. Denckla has been awarded the Lucy G. Moses Prize in Clinical Neurology at Columbia University, the Norman Geschwind Memorial Lectureship at Orton Society, the Rita G. Rudell Memorial Lectureship at Columbia University, the Herbert Birch Memorial Lectureship at the International Neuropsychological Society, the Soriano Guest Lectureships of the American Neurological Association, and the Bernard Sachs Lectureships of Child Neurology Society. The overarching research of Dr. Denkla's career has been to examine the relationship between reading disabilities and ADHD. So she presents to us a perspective from the direction of child neurology and reading disability towards ADHD, and our focus has been in some ways in the opposite direction. It's a distinct pleasure to introduce you Dr. Denckla, that will give the lecture of the day. The plaque. Congratulations.
Hope I can get to my name up here. Is this working? No? Does anybody know how else I can get my name to come up? Where does the thing move? I don't know. Oh, the person told me how to use this.
No, you gotta click on your name first.
Oh, okay, fine. Sorry about that. Well, it's a great honor to be here, and with so many people I know and esteem highly and have great affection for who are here today. I wanted to tell you that I have something to disclose, but it's going to come in the very last slide, but I have no traditional things to disclose. I also have to put some of the things said about me in the past tense because I retired at the end of 2017, and I'm actually a professor emerita. Notice my 6 years of Latin is, and so I'm going to sort of go through the piece of my career that is pertinent to ADHD. As somebody already said to me on the escalator coming back here, I was known for work on dyslexia. Actually, this 50 years coincides with, I have a son here who was born just before I embarked upon this. I finished my training and immediately had my second child. So he's here, marking the beginning of this journey. I was not even going to be a neurologist to begin with. I really didn't like neurology at Harvard Medical School because the neurologists I knew there seemed mostly impatient for the patients to please hurry up and end up at brain cutting. And I did not care for them very much. So it was with some distress that in my residency, where I thought I was going to be an endocrinologist, I was sent to the Boston VA hospital where there was a young man, he was only 38 years old at the time, Norman Geschwind, and listened to him talk about pure alexia without agraphia, which was so fascinating to me, in the whole connectionist way of looking at brain functions, how complex functions are built up out of simpler ones, and there were sort of rules of development as well as of connection that would explain things that seem very, very complicated. I had a 10-week rotation with Geschwind. It was at the very start of my internal medicine first year of residency, which parenthetically, for the ladies in the audience, I had to fight for because I was the first person they'd had as an intern at the Beth Israel who was a female. It took only one a year. And they never had anybody want to stay because they said, oh, they all go into psychiatry. So I had to be re-interviewed in order to even stay for a year of internal medicine residency after my internal medicine internship. But I went to this rotation and was so fascinated that I said, I want to go and train in neurology, and I want to go and train there. Now, the Beth Israel Hospital is a Harvard-affiliated hospital, and any of you who've spent any time in Boston know that it's a very snobby place. And so my chief of medicine said, well, it's fine if you want to go into neurology after this year, but you can't go there. It's a Boston University service, which is like third place down from Harvard. It went Harvard, Tufts, BU, and you don't go there. I said, well, that's where I want to go. He said, well, I will not write you a letter. So I called up Norman Geschwind. He said, I don't need his letter. You've been here for 10 weeks. So that's my first unorthodox move. I went, I guess my second. My first was to ask to stay on as a future endocrinologist in internal medicine. So I went to Geschwind's service with no letter from my chief of medicine, just based on how I performed with 10 weeks on the job. So it was wonderful. And not only did I have training with Norman, but also with Edith Kaplan, who is widely called the mother of American neuropsychology, and everybody here who goes to INS meetings or has any contact with, and you know what she's done, which is so fabulous, is to get the Psychological Corporation to actually underwrite doing some really widely normed tests like the Dellis-Kaplan Executive Function System and also the memory test that she did with Dean Dellis. So she was just fantastic. And Norman was one of the most articulate people you will ever meet, and also someone who really cared about patients and was so different from the neurologist I had described as in my medical school who turned me off. So then I finished my training and I went to New York. The first day I'm there, I think I'm going to be Norman Geschwind and deal with adults. And there is Sid Carter, who is the professor of child neurology, and he says, welcome. I want you to come to child neurology clinic every Wednesday. And I said, what? And he said, I want you to see every child who is late to talk or late to read, because we don't know about talking and reading. We know about a lot of other things about children, but we don't know about this, and you trained with Norman Geschwind. So, okay, with fear and trembling, and glad that I at least had 2 children at home who were developing to sort of watch as my Piagetian entree into the field. I went to child neurology, and they were wonderful because I have one virtue that I recommend to other people. I'm not embarrassed to ask and say I don't know something. I highly recommend that to everybody at every stage in your training. So I would just see a child and I would say, I don't understand what's going on with this child's motor exam. And I'd come outside and grab one of the real child neurologists and say, this is what I found. And they'd say, oh, don't worry about that. That's normal for a 4-year-old. And I'd say, oh, how do we know that? And they'd say, well, we kind of just know it. And of course, not having trained in child neurology, I didn't just know it. And this actually really spurred me on to want to do some more research for my own benefit, really more clinically than anything else. Meantime, I was seeing some adult patients. I did actually get to see a couple of really exotic adult cases of pure alexia without agraphia and pure word deafness, which is really, really extraordinarily rare. But meanwhile, people were asking me more and more to see children and less to see adults. And then I applied for research grants, and we got to the real Sutton's Law, go where the money is, because nothing about adults got funded, and everything about children with dyslexia got funded. So I also was teamed up with Rita Rudell, who really was the person who trained me in research methodology. Rita Rudell was a neuropsychologist who had worked with Hans-Lukas Teuber, who was a neuropsychologist who was up at MIT already by the time I met Rita, but Hans-Lukas Teuber had been at Mount Sinai and worked with some of the neurologists there. And he had studied gunshot wounds in battle of World War II veterans and had sort of appointed Rita, as she said, just because she was a woman, to go and study what they called brain-damaged children. And Rita had that experience, so she introduced me to what I call the 4th dimension of localization, that you can't just look at where things are in the 3-dimensional model of the brain, but you have to find out when they check in. And the fact that there's a range, that it isn't just a chronological age at which a certain connection is made, but there's a range at any chronological age of when these connections actually are made and then myelinate. And she brought extensive experience working with brain-damaged adolescents and children, and she was a very tough critical thinker and writer. As many people said of Rita, I don't know how you work with her, Martha, she doesn't suffer fools gladly. So I said, well, you just have to be very careful not to be a fool around her. So here's the trio now, Rita Rudell on my far left, and Norman, of course, again, and Edith. And those are really the 3 people who trained me in all the basic skills that I've had. And the strange coincidence was that the big diagnosis was MBD, minimal brain dysfunction, and my initials actually are Martha Bridge Denckla, a fact that was laughed about by several colleagues. I was lucky to be actually living in New Jersey and going across the GW Bridge to Columbia because they had established classes for the neurologically impaired prior to there being a law having to do with learning disabilities. I don't remember who exactly was the person who pushed this through, but this kind of class required a normal range IQ, and you had to see a neurologist who would state that brain dysfunction was found. It was left very broad. And the school systems paid me. So my clinic that I started in New Jersey was really a publicly funded clinic. That is, the townships, New Jersey having been settled by the Dutch, has counties, of course, had a Bergen County, but it had townships, and each little township had its own special education leader and procedures. And so I had this wonderful opportunity to see children without any regard to their insurance coverage or any other consideration. Now, how was I going to establish brain? Well, the lifeline of the neurologist is the motor exam. It's the thing we cling to as a marker that tells us what's going on in the brain. But what I had to learn, again, and what I had learned from going to those clinics, was that there are things that are motor signs which are not signs of any permanent pathology, but are signs of developmental maturity, the status of a particular child at a particular age with respect to development. So if you had data, you could start to say that there were anomalies of motor development, and I carefully don't use the word abnormalities, that were basically immaturity. Had the child been younger, the finding would have been normal. So that's when I went forth to do my first solo research project, which was simply to do a somewhat more quantified motor exam. The pragmatic purpose was for me to be able to say I have data from New Jersey about New Jersey children to say who could be in a class for the neurologically impaired. And you know that those of you who are young don't remember, minimal brain dysfunction was about as broad an umbrella as you can possibly think. I mean, it included what we now consider to be ADHD, although then we only said hyperactivity, and I don't even remember whether we mentioned inattentiveness. And we had reading disability and math disability, but the thing that got you into the class was being declared neurologically impaired, which the motor system afforded a good entree into if you had data. So I formed a partnership, and this again for younger people sounds incredible. Didn't have to go to an IRB, went across the river to Fort Lee, met Dr. Block and the child study team, shook hands. He said, all I want you to do is come and present your project to the PTA. We'll send flyers home. They sent me out one child at a time from kindergarten through 6th grade. At that time, they went through 6th grade in the elementary school for 15 minutes per child. And I just developed this exam. And I was my own research assistant. I was my own person who ran to the mainframe computer and put those crazy little punch cards into the machine and did the whole thing by myself. It just seems incredible now, which is why I have such trouble giving advice to younger people, because we did, all these things were done on a sort of like a handshake and I trust you and go for it. Now, the interesting thing is if you then referred back to what you knew about the brain, you started to be able to refer the motor system and the development of these controls back to circuits of which the frontal lobes would be the top commander of the circuit. And thinking back over what I learned about development, the convenient fact that the motor system can be the canary in the coal mine. The motor system can sort of tell you, I'm the harbinger of the rate of development of these different subdivisions. I'm only speaking of the frontal lobes, but could be at the basal ganglia level, could be at the cerebellar level, but it's easiest to think about the top level and was most accessible, obviously, by most of our pre-MRI, for instance, electroencephalographic investigations. So that was sort of a theme, and ADHD eventually we came to be able to think of as dysfunction across frontal circuits. And this motor circuit, which is quite a nice visible chunk with only a little bit of it kind of lapping over into the mesial surface. By the way, the enuresis that was spoken of, the bladder control is on that mesial surface, sort of right underneath where the foot area is. So developmentally, the control, especially of the sleeping bladder, has a lot to do with the maturation of the motor system. But there's also the prefrontal, and then what you can't see too well, and what most of us don't draw such a good picture of on the blackboard, is that whole mesial system, the cingulate, the orbital, the mesial parts of the frontal lobe, which have so much to do with socio-emotional control. And a nice rule of thumb, if you look at myelination of the circuits, our average age of good enough for life is 15 for the motor control, 25 for the cognitive control, and I'm sorry, it's only half as long. It's 32 and a half for the, it's only 7.5 years. That's half of the nice fives. But you can think about the fact that the plus or minus is that 35 is sort of the lagging end of the good enough for life developmental myelination curve for the socio-emotional control. And it conforms quite nicely to your experience of children clinically. So the motor system, which I first embarked upon using strictly for the pragmatics of getting children put in classes for the neurologically impaired, turned out to be a good first thinking entree into how would you look at the development of the brain when you came to what was to become ADHD. Now, magnetic resonance imaging, when we finally got to that, looked at motor control at the level of the basal ganglia, maybe because it was just easier, and later the frontal. And we used magnetic resonance imaging, I'm now skipping forward into the 80s and 90s, anatomically, then functionally, then using diffusion weighted, which gives you pathway information, especially myelinated, and then what I prefer to call non-task elicited, because I don't think the brain is ever resting, but people call it resting state, these fluctuations that reveal connectivity. And to study the development of automatic motor inhibition, transcranial magnetic stimulation study, one of the authors of which Dr. Stuart Mostovsky is here today, and motor mirroring specifically as a subcategory of overflow could be studied with a direct TMS study. But back to the pre-ADHD even terminology days. In 1978, I published a paper with Rita Rudell in the Annals of Neurology, which has been and still is the official big journal for child neurology to intersect with the rest of neurology, called Anomalies of Motor Development in Hyperactive Boys Free of Learning Disabilities. Now, this is another interesting story because I got a letter by return mail from the editor saying, we're not going to publish this, everybody knows this. And here I will give a little advice because I don't think this goes out of date. So I wrote back to the editor and I said, that's really very disturbing to me. Could you possibly send me the references? Next thing I got a letter saying, oh, well, we'll publish it. So I mean, basically the editor, who was an adult neurologist, he wasn't interested in the field. He really didn't want to put it in the journal. But he had made this excuse that everybody knew this, but then he couldn't come up with publication. So that's something you can still do if you know for sure that this person is just kind of like, you know, bluffing you. Now, we've had many, many publications since then, when in 1980 we finally got the terminology of ADD with H, without H. We've gone through all the changes of the name. By the way, I detest the name. As somebody who likes language, why do we have a deficit disorder? It's a double negative. Also, the emphasis on attention is perhaps a little bit excessive. But at any rate, I shouldn't bite the hand that has fed me. I got plenty of grant money, but it's not the greatest name. And we did many publications in later years documenting the indirect significance of motor signs to ADHD. I think the most exciting moment was in 2011 when there was a publication on transcranial magnetic stimulation and mirror movements that was published in another major neurology journal, Neurology. And Dr. Stuart Mostofsky, as I said, along with Don Gilbert, was one of the authors. And it was accompanied by an editorial by Jonathan Mink, who is a very prominent child neurologist, who called it faulty brakes. In other words, because it showed that there were real physiological deficiencies in the inhibitory system. And I'm also going to give a little career advice to people. I'm not an author on that paper, because by the time these young people did this, I had sort of inspired them to do it, but I didn't do the work. So I didn't stick my name on the end of the paper. And I commend to people as they get a little bit further along in their careers that they don't always have to put their name on the paper just because they were the senior person in the group. And then recently, you all have seen in psychiatry writing, people talk about a motor endophenotype of ADHD, which is nice to see that that has come along. Now let me go back a little bit on the sort of more general career perspective. Child psychiatry relationships, a tale of two cities. At New York's Columbia Neurological Institute, I was immediately, I think within 1 year, given a joint appointment in the Psychiatric Institute that was across the street, even closer to the windswept Hudson River. And we had a great relationship. Rita Rudell's appointment was in psychiatry, as many psychologists of any ilk were. And I felt very comfortable with this relationship. When I returned to Boston, I asked whether I could have a joint appointment, and they said, oh, no, we don't do that in Boston. We don't have joint appointments. They didn't go into great depth about it, but anyway, but there was an oasis of ecumenical spirit at the Children's Hospital. And that's where, Joe Biederman was there as a fellow, so he can testify. Really, Peter Wolf was a great influence on making that spirit. Interestingly enough, also, there was convergent validation of the motor work by Peter Wolf and Deborah Weber and some other people, in that they had found choreiform movements, which are these very minor, they're not chorea, because they're not big enough to see across a room, but they're very minor lapses of posture holding in the fingers. And they had found that these correlated with teachers' ratings of attention, not a diagnosis of ADHD, but teachers' ratings of attention in school systems. So we had a lot in common, and the clinic, of which I was privileged to be the director, the LD clinic, was housed in neurology, but we had child psychiatry fellows such as Joe Biederman rotating through, and we also had neuropsychology, we had reading specialists, we had a language specialist, we had a math specialist. Never have I met as good a math specialist in my entire subsequent career. So we had a wonderful clinic. One other person who was there as a trainee was a great guy whose name is escaping right now in Colorado. Oh, Pennington. That's right, who later wrote so much about developmental executive function. So we had some people, I didn't even know them at the time, who would show up at the clinic, and it was a great experience. But no official appointment in psychiatry. During that period of time, we also came across this entity of nonverbal learning disability, which rose and fell. And the main reason why it fell was because it totally neglected anything that would have to do with the kinds of control mechanisms that we subsume under ADHD. A neuropsychologist named Byron Rourke highlighted what he called the right hemisphere syndrome, which he popularized. It started off with the math as the index symptom, but he made a rather broad brush claim that all the right hemisphere dominated functions, which we had sort of neglected because we were so obsessed with the left hemisphere and language and reading, with social cognition. And of course, social cognition then became very popular. I think it was just slightly preceding the renaissance of interest in autism as a neurological condition. One of my friends and colleagues, Dr. Keisha Veller, was interested in social perception and actually made up a test for affect recognition in children, which led her to look at all of her cases of left hemiplegic cerebral palsy. Now, the interesting thing was she found that most of them had ADHD. And she pointed out that if we were talking about a right hemisphere syndrome developmentally, that how come we were sort of stuck behind the frontal lobes, and we were sort of sitting back there in the parieto-temporal region, according to Dr. Rourke, and we somehow didn't throw in this 1/3 of the cerebral cortex that's frontal. So there is an important connection made right then and there between ADHD and social attention, perception, cognition. Then also nonverbal LD was a term applied to several genetic disorders, such as Turner syndrome. And Deborah Weber, to whom I referred earlier in my Boston era, did a wonderful paper showing that we really couldn't say that it was nonverbal in girls with Turner syndrome because they had verbal fluency deficits, which neuropsychologically puts it squarely in the left frontal lobe. So nonverbal LD, it rose and it fell, and it was so interesting that the reason that it fell was because it just sort of turned a blind eye to all of these cognitive intercepts with ADHD and the features thereof. Now, in the NIH years, I was in exile from academia officially. I had a wonderful program portfolio. I was a program administrator. I wasn't a researcher. But I had this program on autism, Tourette, and ADHD, which was very nice. I got to read and read and read and read. It's the only time in my life when my on-the-job time was about 50% spent reading journals. And the research opportunity was afforded by a benevolent boss. Here again, young ladies, the role of luck, brute luck. I had a boss named Sam Draghi, who, if you were a previous aficionado of the Prairie Home Companion, was the son of a Norwegian Lutheran minister from Minnesota, and he was Minnesota nice. And Sam Draghi looked at my previous employment and he said to me, "Do you know anybody here you can do research with? Because you can do this job in 4 days and I'll look the other way and you go do research 1 day a week." Isn't that amazing? I mean, this is an NIH job where you sign in and sign out and you have all these rules. Sam said, "Well, you can do the job. As long as you're doing the job, I'm not noticing that you're not here 1 day a week." So I knew Judy Rappaport. And I trotted over and had a meeting with Judy. And she hooked me up with Judy Rumsey, and I got back into doing dyslexia research. And we also hooked up with Danny Weinberger. We did some work with him. And basically, I was back on my academic publishing schedule of putting out 3 to 4 papers a year. But it was really thanks to that fantastic man who said to me, "You can do it," which is, you know, one of those things you can't plan in your career at all, to meet up with nice people. I also went to the NIH genetics clinic because I was connected with the whole Tourette community, and they wanted me to and I met up with people who said, "Hey, you know, there's this thing called neurofibromatosis 1, and the teachers are very scared of our children. They say, 'Oh my God, I don't know how to treat your child's learning disability because you have this disease called neurofibromatosis 1. We don't know what to do. So could you please do some research on neurofibromatosis 1, which started me off then, and that was quite a long 15 years I did some research on the learning disabilities there. I met through the program duties most of the autism research community. Happy to say that I got a couple of very famous people off to their first grants. And that also is why I dropped autism when I went to Hopkins, because I felt it was too much of a conflict of interest, because I'd been so involved with jumping off points of the careers of people, including Susan Folstein at Hopkins, so that I didn't want to, step on toes, even beyond the period when it was considered, ethical for me to do so. I love the Tourette syndrome people. It is absolutely the most fantastic NGO group I have ever worked with. They are such great people. So I was on their scientific advisory board for 25 years, and I really still miss going to those meetings because they were just wonderful. And there too, Tourette syndrome was so interesting because it had such a high comorbidity with ADHD, and yet I began to get the flavor that maybe those who were non-comorbid would be quite different from the slight majority who were comorbid. Now then, I was recruited to go to Kennedy Krieger by another fantastic person, Hugo Moser. I always have to say apologetically to the feminists, I'm telling you about all these wonderful people in my career, and I'm sorry to tell you they've all been men. Every single one of my terrific bosses, I haven't had a single woman boss, and they've all been wonderful. So I really can't. As a mother of 3 sons, I'm happy that I don't have to ding the male of the species. At any rate, there are lovely people across both genders. So back to joint appointment. At Kennedy Krieger, Johns Hopkins, whatever its faults, and Alan Zemetkin was reminding me of the joke that Judy Rappaport sat me down before I went to Hopkins. She said, I have to insist that I become a full professor before I go there. And then she said, anyway, a full professor at Hopkins is just a hunting license, meaning it positions you to get NIH money. But despite this kind of reputation, they did have a wonderful relationship between neurology and psychiatry. And at this time, not just child fields, but the entire 2 departments. And I was lucky enough to get center grant funding, going from gene to brain to the syndrome of LD. And 2 of the projects were dear to my heart. One was NF1, another one was on Tourette syndrome with Dr. Harvey Singer, who's a wonderful collaborator and still has done a tremendous amount and runs a clinic for Tourette syndrome in the child neurology department at Hopkins. And interesting enough, both were associated with ADHD. The big surprise was NF1, which again had been written about as recently as, I guess it was the 1982 publications, as nonverbal learning disability, with a big emphasis on the social cognition and math problems, et cetera, but whopping big ADHD manifestations also, which I resisted finding, by the way. I didn't want to find that. I was getting bored already with finding ADHD under every bed. But at any rate, and then we began to look at what was this connection? And that's where we came to executive dysfunction, which of course came from the executive function in the cognitive neurosciences field. And also Russ Barkley, I have to give credit to him for having first even injected the term into my thinking. I just want to digress for 1 minute because these are 2 of my favorite research findings that nobody seems to ever read or cite. So I'll take on Tourette syndrome. We did whole family cognitive studies. We had father, mother, unaffected sibling with Tourette, and Tourette proband. And the children with Tourette who had no ADHD comorbidity, those who were pure Tourette, had a failure to regress to the mean on IQ. They had higher IQs than you would expect from the usual mid-parental IQ. So there is some advantage to pure Tourette syndrome. So a lot of the stories we hear about all kinds of great achievements of people with Tourette syndrome, there's something very interesting there, and it's a real cautionary note about, genetic screening and, should we play God about who has which genetic disorder, because Pure Tourette, when it doesn't have the ADHD comorbidity, is associated with unusually high intelligence. Nobody seemed very excited by that. It was published in a neurology journal, but somehow neurologists are not interested in hearing good news, I guess. At any rate, hopefully psychiatrists are more so. And then a longitudinal study using this wonderful longitudinal statistical analysis of NF1 probands and their unaffected siblings with a whole bunch of neuropsych tests in different domains. What we were looking for was to see whether over time, over 5 visits, we would find that over a 5-year period of time, NF1 children would, jump the curve and be more like their siblings. And this happened only in one domain, and it's the most environmentally influenced one, language. No other domain jumps the curve. That is, that the difference between to the deficit side of the children with ADHD, the children with NF1, including their ADHD, remains over this 5-year follow-up. But the family with whom you have your conversational interchanges seems to have a greater impact than you're having a genetic disorder. So that was one of my never quoted favorite studies that I've published. So how about the impact of executive function on emerging LD with ADHD? When we had that big research project, and we had these children come in as controls for the Tourette's, because we had Tourette's with and without ADHD, and we had ADHD children. The 7-year-olds, the 8-year-olds with ADHD, they tested well academically, but we saw them over a 5-year period. Even followed for 2 years, those with ADHD fell behind. The first thing was writing. The second thing was reading comprehension, falling behind by 3rd grade. Long division, which has a great deal of executive function in it. When you think about it, you have to form a hypothesis and test the hypothesis and change your strategy or your tactic anyway. And this falters whenever it is that long division is introduced. And persistently long-form written expression disorder, which requires a lot of planning and organization. So you would see emerging official academic shortfalls, even though there was no indication of any of the risk factors for a specific disability early on. There's been a growing concept of executive factors as mediators of cognitive and social adaptation. The research findings of neuropsych tests are inconsistent. I think I would add my editorial comment that part of this is because we don't have a lot of looking for cofactors. I think it's a lot harder the more highly intelligent the population is to find a testing, because it's like Heisenberg's principle of indeterminacy. You're sitting there one-on-one giving a test, so you're not putting the person out there to be an independently functioning person. And that's where you would really find the executive deficits. And if you don't realize that and try to design experiments that put more burden upon the subject to be independently generating their executive function rather than you being this guiding light, you won't see it. Ratings like the brief are poorly correlated with actual neuropsych tests like the DKEFS. That doesn't surprise us because we know it's the brief is going to be seeing you in a different way, again in a more naturalistic setting. And it's like our other ratings for any other disorder for which we obtain ratings, the different circumstances are going to make you look very different. There's been a growing distinction between cold and hot, which I correlate cold with cognitive and hot with social emotional executive function. And social emotional or hot executive function, of course, is even more difficult to document than the more cognitive things, because you just can't, you have to make yourself a fly on the wall. And I think we'd have to do very expensive things like getting permission to videotape with blurring out of faces to really measure how children, adolescents, adults actually manage themselves in social situations. This is apologies to Howard Gardner. The outside trays of this Lazy Susan are all Howard Gardner's different kinds of abilities. I stick the executive function in the middle, which Howard didn't, because I believe that you cannot understand how we compensate. I always give the example that I am very poor at spatial where function. I can't find my way out of a paper bag, but I use language to very carefully label every place I've been, like parking lots. I memorize the color and the name of the various pillars of the multi-level parking lot. I still sometimes get lost because I turn the wrong way. But anyways, and then we have all of these other ways that we can compensate by dipping. If you will think of a Lazy Susan where you could have the tray twirled around by your executive function, so you dip into some other function. Also developmentally, sometimes people talk in very highfalutin terms about metacognition. Well, metacognition really is way up there in step 6 developmentally. We start with inhibition, and then we add working memory, and then we have organizing things and spaces, and then we have time-based planning, and then we have actual generating strategies, and finally we get to know thyself. And that's what metacognition really is. But people tend to talk about it in such a way that it sounds too complicated and too inaccessible. But at any given stage of child and adolescent, we have to think, where are we along this course? And you are all very aware of this. This comes out of papers by Bush, 2011, and Durston, 2011. So we have behavior, cognition, brain, but cognition really needs to be split into those hot and cold subdivisions. I've been teaching neurologists and educators pretty much equally for the last 10 years before I retired. I think Max Wisnister is here. He was the guy who taught with me for about a decade at the Academy of Neurology. Usually we taught at breakfast, so only intrepid souls made it to the course. And he talked about pharmacological management. I talk about non-pharmacological management of ADHD. That's my emphasis, is essentially other than pharmacological treatment. And I'm a big fan of behavior modification, ABC, remarkably underutilized. Amazing to have people come up after lectures at the Academy of Neurology and say, I'm from, and they'll give you some reasonably well-populated Midwestern city and say, I never heard of a behavioral psychologist. Really amazing. Executive coaching can be a standalone help for academics, or it can be within a more expanded cognitive behavioral therapy frame of reference, depending on what your target symptoms are. I've also been giving lectures and seminars in a master's program at the School of Ed, and then later at Kennedy Krieger, where we have a Center for Innovation and Leadership in Special Education, training people to be leaders in the field in whatever capacity, maybe even starting their own special schools. So the current concept of primary ADHD, that is ADHD that we have these, 12 different genes? At least it's better than autism, which last count was over 100. A true example of developmental delay. I think so. I think we may find that that's true. If so, though, it's not trivial because it's 3 years, which is a big chunk of childhood and adolescence. And the consequences of a 3-year lag can be crippling because of all the emotional things that can happen in that time, which become far more woven into the person's prognosis. The evidence for ADHD differs from dyslexia's different architecture, which really is you have a different kind of brain. It's just built differently. It has different talents. So these are exemplify 2 types of what I call inconvenient brains. One that's on the lagging side of development, and the other one that's simply a different brain. It's always going to be that way. But these other talents, if people will just let you get through school, yes, Virginia, there is a life after school. Just not only there is a Santa Claus, but there is a life after school. We all know Shaw's wonderful work. about the maturation being later in ADHD, and a lot of evidence, I think, that's now accumulating about the myelination in the adolescent decade being delayed as well. And this is what I had to disclose, is that I've just published a book. And this book is, this is a book that was in response to requests by parents at parent conferences in my little clinic, and it's also based on seminars with teachers. So it's really a book for parents and teachers, and it's small. It actually fits into a medium-sized purse for a lady. You know, it's only 130 pages long, doesn't have a whole bunch of references, has some websites to go to, and it has 10 chapters. The ones that I think are of most general interest are the first one that talks about what are the things that develop in the brain during the school years, rather than always the emphasis of prenatal and 0 to 3. And then the second chapter is factors that actually enhance brain development, which include sleep, play, music, and foreign language early. And then the next to the last chapter is called neuromythology. And it's about all the things that the popular press or magazines put out that they think say truths about the brain, which turn out to be misleading at best. So this is where I ended up. And just for the further amusement, the cover boy is actually my older son, older than the one who's here, who is at age 7 is gazing with just the right expression I wanted for the cover of the book at a piece of schoolwork. So I looked at so many images on Google Images, and then I looked up on my shelf and I said, you know, Matthew has just the right expression for what I wanted on the cover of the book. So it's a family affair. I have Matthew Denckla expressing his inconvenient brain looking at this piece of work. Thanks for your attention, and thanks for this great honor. Questions? It's too late? A couple of questions? Okay, 2 questions. Somebody want to ask? Meryl.
I have a statement, and I think this statement will probably reflect a lot of us in the audience. Well, you have never been my boss. You have always been my professional leader.
Oh, thank you. Anybody have a question? Okay, well, if not, okay.
I'm at Hopkins, and I've interacted with you over the years when I was a resident. But I wonder, you know, you're such an incredibly successful woman at a time when women really were not welcomed into medicine. We have a room, half of which now are women. I wonder if you could just speak to that a little bit.
Well, as I said, I have to attribute a great deal to just very good fortune. Very good fortune. You know, I talked about the little bobble where they were sort of, you know, what, you want to stay to be a first-year resident in internal medicine? We're going to have to interview you all over again. So there was a little bit of that, you know, we've never had a woman do this before. But by and large, I have met with really very, very little difficulty. And I don't know why that is exactly. I think probably the only thing I can say that's helpful is to have a sense of humor, you know, and maybe not get too offended by every little thing you think might be, you know, not to have a chip on your shoulder and sort of, you know, and as I said, like handling the editor, just handle it straightforwardly by saying, oh, would you please send me the references? So I guess it's being a combination of assertive and a little bit kind of having a sense of humor. Thank you.
Can I have the mic for a moment? Okay. I think that we unfortunately have to thank you for considering. I wanted to thank Dr. Denckla for an exceptional presentation of her life achievement, and more than anything, to be an inspiration to all of us. Many thanks. And I would also like to invite all of you to attend the data blitz that is starting as we speak. Thank you very much.